James Miner, Senior Associate Editor for Electronic Publications at Academic Emergency Medicine. And it's my pleasure to be talking to Dr. Paul Musey today, whose manuscript, "Do Gender and Race Make a Difference in Acute Pretest Probabilities in the Emergency Department," is the editor-in-chief pick for the month, picked by Deputy Editor Chris Carpenter. This is a great paper, and I'm excited to talk to you. Thanks for joining me.
Well, thanks for inviting me. It was an honor to be picked.
Well, it's a great manuscript. Let me just start with, how did you do this study?
Well, so first of all, I decided to do it because, as you know, after working on the consensus conference, one of the big themes coming out of there was trying to put gender stratification or reporting that information in all manuscripts. And I had been working with this database before, looking at low-risk chest pain and anxiety, and I said, well, I've gotten pretty comfortable with it. Let me go back and take a look and see if there's anything with gender. And for a number of reasons, some of them obvious, I decided, well, let me take a look at race too to see if there's anything there. And so what we decided to do was basically stratify the population of 851 chest pain patients by either gender or race. And primarily we were looking at their pretest probabilities, both subjective and objective, and then we looked at some of their outcomes.
Sure. And how did it go?
It was actually quite surprising. So from looking at the literature and from knowing what's going on just in healthcare in general, we expected there to be some disparities. What we were actually surprised by, so what we expected was that the pretest probability that providers would give would be lower for women and for minorities. What we didn't expect is that the workup that seemed to come after that didn't seem to change no matter what the pretest probability was.
Sure.
So I guess put simply, subjective pretest probabilities were assessed by the VAS score. So providers were given a VAS score and then asked right after they had just finished seeing the patient, it's like, what is your gestalt that this patient has ACS? And they marked on the line. And so it corresponded to 10%, 20%, whatever that was. Sure. And then we used objective pretest probabilities using the pretest consult ACS tool, which is a web tool designed by Jeff Klein. And so that assigns an objective pretest probability. And so what we actually found is that those two numbers, the subjective pretest probability, corresponded with the objective pretest probabilities, meaning in that for both non-white patients and female patients, they were lower than their counterparts significantly. And so that was interesting in and of itself. And so what I expected to see was that the costs and radiation exposure and basically workup would be less for those populations, taking into account that physicians thought they were lower risk, they were objectively lower risk, but we didn't see that. I mean, we basically Sure. saw that costs and radiation exposure remained the same. There was really no difference in returns to the emergency department at 90 days. There was no difference in their levels of the rates of ACS. So it was actually counterintuitive to what I expected and counterintuitive to what a lot of the data would have us believe.
Yeah. So boiling it down, how would you use your findings?
Well, so I think, so I guess the first caveat, I mean, obviously this is a unplanned secondary analysis of this paper, of this database. So we weren't, the database wasn't set up to ask this question. But I think going forward, I think we do need to ask this question. What role does our pretest probability play in how we evaluate patients with chest pain? That I think ideally, I mean, you have a level of risk that you think the patient meets, and you match your workup to that level of risk. And so we didn't see that in this case. And I don't know why that is. I mean, like I said, we talk a lot about racial and gender disparities. Perhaps chest pain is one of those things that people are, I mean, there's enough out there about it that they have their own normal workup that they do on everybody because they don't want to miss anything, no matter what they thought of their risk coming through the door. So I think it kind of informs what we already know about disparities, and I think it's an interesting question going forward.
Sure. So what is your plan going forward?
Well, so obviously, I mean, with my studies going forward, I'm going to take a look at this question specifically. So using the VAS score to quantify what the provider thinks the pretest probability is, and then use the objective pretest assessment tool again, and then see what their actual workups are. So we used costs and radiation exposure as surrogates for workup in this study. So I actually want to know, like, how many of these people are getting X number of troponins and actual X-rays and CT scans and being brought in for observation. I just want to know if there's any difference. And so that'll be a study that I'll be launching in the near future.
Yeah, one thing I personally found really cool here is your use of visual analog scales. I've used them as a pain researcher my whole career. And the big problem is they've always been an opinion. It's an opinion-based scale, so it's hard to use for something like that. But this seems like the perfect use for it.
No, absolutely. I mean, to provide, I mean, it's basically asking, it's like, what is your opinion that this patient has acute coronary syndrome?
Yeah, and that's the weakness and the strength of the scale, I guess.
Well, I mean, it's amazing because you would expect. So one question I got was, well, perhaps there's a Hawthorne effect. And I was thinking, well, it's like these people, the providers, they all knew that they were being studied, that this was a specific question that we were asking. And I guess if the Hawthorne effect was really playing a role, you would expect that people would normalize their gestalt so that it didn't seem that they were rating women or minorities less. But I think that it just shows that whatever we use as input for our own medical decision making is playing a role. I don't know if there's a little bit of unconscious bias. I don't know if that we can really say that with this study, but I think it does feed the data that's already out there that there is some unconscious bias in medicine in general.
Yeah. Well, it's really cool work you're doing. It's especially cool that you're doing this as an unplanned secondary analysis. You're adding such interesting work onto something that was already done. It's really cool to see the data maximized like that.
Absolutely.
Congratulations. All right, one final question.
Absolutely.
Who's going to win the Super Bowl this weekend?
Oh, absolutely. Atlanta Falcons.
All right. I'll have to get you up on the website before the game, though, so we can.
Okay, exactly. Hopefully I'm not eating my words after the game.
Yeah. Well, thanks a lot.
Awesome. Thanks.
Well, we're good. So thanks for your time, and I'll talk to you again soon. It's always a pleasure to see you.
Definitely. I mean, everything is going great up there.
Oh, yeah. It's awesome. Yeah.